If you have been told your knee pain is arthritis, I need you to stay with me for the next few minutes, because there is a very high probability that what you have been told is incomplete. Not wrong in the sense that arthritis does not exist, or that your imaging does not show wear in the joint, but incomplete in a way that matters enormously for whether your pain gets better or keeps getting worse. In 15 years of clinical practice, I have watched patients manage knee pain for years, sometimes decades, with anti-inflammatories, injections, and eventual surgery conversations, while the actual mechanism driving their pain was never identified, never addressed, and continued operating beneath the surface of every treatment they received. I am Dr. David Miller. I built this channel because there is a gap between what the research says and what patients are told in a standard clinic visit. And that gap has consequences that are entirely preventable. Subscribe to Dr. Miller right now and hit that like button. We are working toward a community of people who understand their own bodies well enough to ask the right questions and recognize when the answer they are getting is only part of the picture. Every subscriber makes this channel more visible to the next person who needs it. Let me tell you about a patient I will call Patricia. She was 64 years old. She had been living with knee pain for 6 years, both knees, but the right significantly worse than the left. She had seen her primary care physician, an orthopedic surgeon, and a rheumatologist. She had 2 MRI scans. She had received 3 cortisone injections into the right knee over 3 years. Each injection had provided 4 to 6 weeks of improvement, followed by a return to the same level of pain. She had been told she had moderate osteoarthritis and that she was not yet at the stage where knee replacement was indicated, but that she was heading in that direction. She had accepted this as her situation. She came to see me not because she expected a different answer, but because she wanted to understand what she could do to slow the progression. When I sat with Patricia and went through not just her imaging, but her full clinical picture, including her movement patterns, her daily activity, the specific location and character of her pain, and a set of simple physical assessments I will describe shortly, the picture that emerged was significantly more complex than moderate osteoarthritis. Patricia did have cartilage thinning visible on imaging. That was real. But the driver of her daily pain was not primarily the cartilage loss. It was a combination of 3 separate mechanisms that were operating simultaneously, none of which had been directly addressed by any of the treatments she had received. Understanding those 3 mechanisms is the entire point of this video because they apply to the majority of people over 60 who are living with knee pain and calling it arthritis. Before I explain the mechanisms, I want to be precise about what osteoarthritis actually is, because the word is used so broadly and so loosely in clinical practice that it has become almost meaningless as a diagnostic term. Osteoarthritis is a condition in which the cartilage that lines the joint surfaces degrades over time. Cartilage is the smooth, shock-absorbing tissue that covers the ends of the bones where they meet in the joint. It has no blood supply of its own. It receives nutrients from the synovial fluid that bathes the joint through a process of compression and release during movement. When cartilage is loaded normally, moved regularly, and supplied adequately, it maintains itself reasonably well even with age. When it is overloaded asymmetrically, kept still for extended periods, or subjected to chronic low-grade inflammation, it degrades. The distinction between those 2 scenarios is everything, because the first is age and the second is a set of modifiable conditions that nobody sat down to identify. Here is the critical fact that most people are not told at their appointment. The degree of cartilage loss visible on imaging correlates very poorly with the degree of pain a person experiences. Studies consistently show that a significant proportion of people over 60 have MRI findings consistent with moderate to severe osteoarthritis and report no meaningful pain, while others with relatively mild imaging findings report severe daily pain. The cartilage loss is part of the picture. It is not the whole picture, and in many cases, it is not even the dominant driver of pain. The first mechanism driving knee pain in the majority of people over 60 is muscular insufficiency of the quadriceps, and I want to explain this in enough detail that you understand exactly why it matters and exactly what to do about it. The quadriceps is the group of 4 muscles running along the front of the thigh that straighten the knee and, critically, control the descent of the knee during loading. Every time you take a step, every time you sit down or stand up, every time you descend a stair, the quadriceps is the primary shock absorber for the knee joint. It controls the rate at which the knee bends under your body weight. When the quadriceps is strong and well-conditioned, the impact of each step is distributed across the muscle before it reaches the joint. When the quadriceps is weak, that impact goes directly into the joint structures. The cartilage, the meniscus, the subchondral bone beneath the cartilage, these structures absorb the load that the muscle was supposed to absorb. Over months and years of this pattern, they show the consequences. The relationship between quadriceps weakness and knee pain is one of the most robust findings in the entire field of musculoskeletal medicine. Studies consistently show that quadriceps strength is a stronger predictor of knee pain severity than the degree of cartilage loss on imaging. Patricia's quadriceps, when I assessed them, were significantly weaker than expected for her age and body weight. This was not surprising. 6 years of pain had reduced her activity. Reduced activity had reduced the stimulus for muscle maintenance. Reduced muscle had increased joint loading. Increased joint loading had increased pain, which had further reduced activity. This is the cycle that nobody had named for her and nobody had directly interrupted. The quadriceps knee pain relationship I just described is textbook musculoskeletal medicine. It appears in every physical therapy training program, and yet the majority of people I see who have been told they have knee arthritis have never had their quadriceps strength formally assessed and have never received a structured progressive resistance program specifically targeting that muscle group. This channel exists because that information belongs with the patient. Hit subscribe. Every subscriber means the next person with this question finds the answer. The second mechanism is synovial inflammation, and this is the mechanism that the cortisone injections Patricia had received were targeting, which is why they worked temporarily and why the effect did not last. The synovium is the membrane lining the interior of the knee joint. It produces the synovial fluid that lubricates the joint and nourishes the cartilage. In a healthy joint, the synovium is thin, quiet, and unremarkable. In a joint under chronic mechanical stress and low-grade inflammatory load, the synovium becomes thickened, irritated, and hyperactive. It produces excess fluid, which is the swelling you can see and feel in an inflamed knee. And critically, it produces inflammatory compounds called cytokines that directly damage cartilage cells and accelerate the very degeneration that the imaging is showing. This means that synovial inflammation is not merely a symptom of knee arthritis. It is an active driver of its progression. A knee that is chronically inflamed is a knee whose cartilage is being chemically degraded from the inside, in addition to whatever mechanical wear is occurring from above. Cortisone injections suppress this inflammation effectively in the short term. The problem is that if the sources of the inflammation, the mechanical overload driving synovial irritation, and the systemic inflammatory signals arriving via the bloodstream are not addressed, the inflammation returns as soon as the cortisone effect wanes. You are turning down a fire alarm without addressing the fire. The 4 to 6 week improvement Patricia experienced after each injection was the synovial inflammation clearing. The return of pain was the inflammation rebuilding because nothing driving it had changed. The dietary contribution to synovial inflammation is consistently underestimated in clinical practice and consistently underexplained to patients. The synovium, like every tissue in the body, is exposed to the inflammatory signaling compounds circulating in the blood. In people with high dietary intake of refined carbohydrates, ultra-processed foods, and vegetable oils high in omega-6 fatty acids, the circulating level of pro-inflammatory compounds is chronically elevated. These compounds reach the synovium and amplify its inflammatory response to whatever mechanical stress it is already under. The joint becomes more reactive, more easily irritated, and slower to recover from each loading event. This is not a fringe nutritional claim. It is the mechanism by which systemic dietary inflammation intersects with local joint inflammation, and it is documented in peer-reviewed rheumatology literature. Patricia's diet, when I reviewed it, was not extreme by any measure. She did not eat fast food regularly, but she was eating refined bread at most meals, sweetened yogurt daily, and cooking with sunflower oil consistently. These were her three primary sources of dietary pro-inflammatory load, and none of them had ever been discussed in the context of her knee pain. The third mechanism is what I call kinetic chain dysfunction, and this is the one that explains why Patricia's right knee was significantly worse than her left, despite the imaging showing similar changes in both joints. The knee does not operate in isolation. It sits in the middle of a mechanical chain that runs from the foot and ankle below to the hip and pelvis above. The forces that reach the knee during walking and loading are shaped by every structure in that chain. When the foot pronates excessively, which means rolls inward during loading, it creates an inward rotational force on the lower leg that translates directly into an asymmetric load on the medial compartment of the knee, the inner portion of the joint where cartilage is most commonly lost. When the hip abductors, the muscles on the outer hip that stabilize the pelvis during single-leg stance, are weak, the pelvis drops on the unsupported side during each step, creating a lateral shift of the body weight over the stance leg that again concentrates load on the medial knee compartment. These forces, arriving at the knee from below and above, determine where within the joint the majority of stress is concentrated. And concentrated stress means concentrated wear. Patricia walked with a visible inward collapse of her right knee during the stance phase of her gait, a finding called dynamic valgus. Her right hip abductors were significantly weaker than her left. Her right foot showed moderate pronation on standing. These three findings together explained precisely why her right knee was worse than her left, despite similar imaging. The distribution of stress within the joint was asymmetric, driven by mechanical factors in the chain above and below the knee that nobody had assessed or addressed. Now I want to give you the practical protocol, organized by mechanism, because treating knee pain without identifying which mechanism is dominant is exactly why so many people cycle through treatments without sustainable improvement. For the quadriceps insufficiency mechanism, the intervention is progressive resistance training of the quadriceps specifically, starting at an intensity that the joint can tolerate and increasing systematically over weeks and months. The starting point for most people with significant knee pain is the seated leg extension performed with minimal weight or resistance, which loads the quadriceps through its full range without placing compressive load on the joint in the way that a squat or lunge does. As strength and tolerance improve, the progression moves toward wall sits, which are static holds in a partial squat position that build the quadriceps under sustained load, and eventually to step-ups and modified squats that replicate the functional demands of daily movement. The critical point is that this is not optional supplementary advice. Quadriceps strengthening is the single most evidence-supported intervention for knee osteoarthritis pain reduction in the entire musculoskeletal literature. It outperforms anti-inflammatory medication in medium and long-term outcomes. It outperforms injections in durability of effect. It is the primary treatment, and it is the one most consistently underprescribed. For the synovial inflammation mechanism, the most targeted immediate dietary intervention is the elimination of refined vegetable oils high in omega-6 fatty acids from daily cooking and their replacement with olive oil, which has a well-documented anti-inflammatory profile, or with butter and coconut oil, which are neutral in their inflammatory signaling. This single change, in the context of a person whose joint is already inflamed, reduces the daily inflammatory input to the synovium from dietary sources and allows the joint's own resolution mechanisms to begin working more effectively. Alongside this, the addition of long-chain omega-3 fatty acids from fatty fish consumed 2 to 3 times per week, or from a high-quality fish oil supplement providing at least 2 grams of combined EPA and DHA daily, directly competes with the pro-inflammatory omega-6 compounds for the enzymatic pathways that produce inflammatory mediators. This is not a general wellness recommendation. It is a targeted biochemical intervention for the specific inflammatory pathway operating inside the knee joint. For the kinetic chain dysfunction mechanism, the intervention depends on where in the chain the primary disruption is located. For foot pronation, a structured orthotic insert that controls inward collapse during the stance phase of gait reduces the rotational force delivered to the medial knee compartment with every step. The difference in medial knee load between a pronated foot and a corrected foot position has been measured in gait laboratories and is clinically significant. For hip abductor weakness, a targeted program of hip strengthening focused on the gluteus medius, the primary hip stabilizer during walking, reduces the pelvic drop during single-leg stance and the associated lateral loading shift at the knee. The clamshell exercise, side-lying hip abduction, and single-leg stance progressions are the primary tools, and the effect on knee pain when hip strength is genuinely the driver is often faster and more dramatic than anything directed at the knee itself. How old are you? Write it in the comments right now. I want to see the age range of this audience because it shapes what I focus on next. If the majority of you are in your early 60s, I want to go deeper on the reversibility of cartilage changes with appropriate loading and nutrition because the evidence here is more encouraging than most people have been told. If many of you are in your late 60s and 70s, I want to address the question of when conservative management has genuinely reached its limit and what the surgical conversation should actually look like, including what the research shows about outcomes after knee replacement in people who have and have not optimized these mechanisms first. Patricia came back to see me 5 months after our first appointment. She had been working with a physical therapist who had implemented a progressive Quadriceps program starting from the level her knee could tolerate. She had replaced her cooking oils and added fish to her diet 3 times a week. She had been fitted with orthotic inserts. At 5 months, her right knee pain on a daily basis had reduced by approximately 60% by her own rating. Not gone. 60%. She told me she had climbed 2 flights of stairs the previous week without stopping to rest her knee. She had not been able to do that in 4 years. She had not received a cortisone injection in 5 months. She was not planning to receive one. The inflammation in her joint had not been suppressed by a drug. It had been reduced by removing the signals that were producing it and strengthening the structure that was supposed to absorb the load before it reached the joint. Your knee pain is real. The cartilage changes on your imaging are real, but the story of why you are in pain and what drives that pain day to day is almost certainly more complex than a single diagnosis of arthritis covers. The mechanisms I have described today operate in the majority of people with knee pain over 60. They are modifiable, they are addressable without surgery, without injections, and without accepting progressive deterioration as the only available trajectory. The conversation that produces that understanding takes longer than a standard clinic appointment allows. That is why this channel exists. I am Dr. David Miller, and I have spent 15 years watching patients accept a diagnosis of knee arthritis as a destination rather than as a starting point for investigation. The cartilage loss is the result of a process. Understanding the process is what gives you the ability to slow it, and in many cases, to meaningfully reverse the pain it is producing. Subscribe to Dr. Miller, hit the like button. Share this with someone who has been told their knee pain is simply part of getting older and has stopped expecting it to get better. It can get better. The biology supports it, the evidence supports it, and now you have the mechanism. The healthcare system profits from managing your symptoms with repeated injections and eventual surgical consultations. I profit from you understanding what is actually driving the pain before you get to that point. Subscribe if that difference matters to you. This content is educational in nature and does not constitute personalized medical advice. If you are experiencing knee pain, please speak with your physician or a qualified musculoskeletal specialist about appropriate assessment and treatment. The mechanisms and interventions discussed here should be explored in partnership with a healthcare provider who can evaluate your individual presentation.